Welcome again. Hope you are enjoying your time here. We are very proud to have you here. Hopefully, this coming and this expo meeting come to a very good results for both your side and our side. So, this is the future of radiation oncology. Why we are saying that? Because, imaging and better imaging is our main issue in all radiation oncology time. And luckily, we have high field 1.5 Tesla MR LINAC. So we have good MR and good LINAC working together. This is the 31st center in the world can have this high-tech device. So maybe Mary Hanum is just thinking why we buy this machine. The main reason of buying of this machine is this slide. Because what is happening here, you can see the very right upper part, the intestines is just outside of my radiation field. But when I invite patient for treatment, this will be the mostly next day, and patient will lie down, so right upper, it is in the treatment table, and now I am seeing that intestines is just inside of my radiation field. And in this case, there is nothing to do in the world. Only thing can do is patients should go outside, maybe some walk or something, and after that, you can start your treatment because you should change inside the anatomy. You couldn't change the anatomy. But what we can do? When patient lying down, you can do replanning. Again, we can plan the patient according to that day anatomy. So this is why MR LINAC is coming to our focus. And then what happened in the MR LINAC inside technology is, so this is a MR device and radiotherapy device together. In the very upper, you can see the device, the radiotherapy device is the bigger one, and the MR is the vacuum tube inside, is just go to inside of it. And then the magnetic field is just isolated from radiotherapy field. It means that radiotherapy device working without magnetic area. So it is just insulated from magnetism, but of course the patient and the table is just in the magnetic area. So can we start the left video? Yes, please start. So this is how it looks like inside. So we know that MR devices, if these are high field, so this is 1.5 Tesla, we know it very well, it should be close. The open ones is not 1.5 Tesla. So as you see, the device and around is just white, the light inside, and also the air inside is very good, so there is no claustrophobic issue. Still, some of you may ask to us, if the patient is still claustrophobic, what can we do? We have also anesthesia equipment if necessary, but most of people, if they believe that the good side of the device, they mostly tolerate it inside of the table. And thinking that if patient is tall and if we are treating prostate, their head is just going outside of the tube. It means that, so tall patient, pelvic treatment, it's almost open. So this is the common question, how much time is necessary? Because what is happening here, we accept the patient. We scan the patient with MRI. So this scanning, this is the patient go inside and positioning. It took 2 minutes. And after patients lie down the table, patient will go inside of the tube and we start our first images in order to look at how everything going inside of the patient. So it again took extra 2 minutes. So now we have 4. And after that, we just double check inside anatomy, how the patient positioned today. It is just sometimes changing all together. It is a little bit millimetric changes. But sometimes whole anatomy may change. It took difference. If whole anatomy changed, then you have to draw your targets each day. We are doing that way. Some of the normal targets is automatically contoured, like medulla spinalis, like parotids, system automatically contoured. But if the tumor change, we have to recontour or redraw our targets. And after that, we start our treatment planning. So this is very cool future. Patient is lying down, we adapt the anatomy, we now adapt our treatment plan according to the anatomy. So this is really cool because previously we don't have this one. So again, after that, I know you are thinking patient in the lying down the machine, and then we are planning. So time is going. You can think that something is changing inside. And we did another MRI in order to see if anything changed during that treatment planning time. And then, after we are ready, we start the treatment. It took around 40 minutes for patient. It can change patient to patient, anatomy to anatomy. Sometimes patients just press the button because they may not tolerate or something happened. Let's say bladder may fail or something bad happened, and they just press the button. And this is another good feature. We can double check everyday's anatomy, and also we can double check functional anatomy. So DVI or diffusion weighted image is also possible with 1.5 Tesla MRI technology. So this is also another good thing. We can also double check how the patient's functional MRI is changing. So this is another good thing. Previously, we need to wait for some response evaluation. Let's say during radiotherapy, it is not easy to say how the treatment is going. But with this technology, again, using DVI images, we can double check how everything going inside of the patient. So we have plenty of methodology to work with, respiratory changes. So this is also important issue because, patients are respirating. There are some movement during respiration. So we have some technologies like stopping some abdominal pressure, decrease the respiratory motion in this way, so it is less movement happening. Also, following the respiratory motion also available very soon. So these are the real patients of mine. So this is my first patient I want to talk to you about. So this is a cervix cancer patient come to us with very big bone metastases at the beginning of at the beginning of whole story. So it is interesting patient because even the metastatic focus, you can see the right one, this one, the metastatic focus is even bigger than the primary tumor. So it is very interesting coming of patient. And of course, we start with systemic treatment. After the systemic treatment, still we have some residual diseases. If you look at the left side, the diseases is still there, even effective systemic treatment. And then we have to do local treatment. We did external beam radiotherapy with Versa HT, and then we have to increase our doses to do some bone and also lymph node areas. But the problem is, intestines are there. So we need to be very careful. Again, we use MR-Linac, so these are the response after MR-Linac or whole radiotherapy. So this is another interesting case. So this is a two-focus rectum cancer patient. One is distal polypoid tumor, second is proximal sigmoid tumor. You can see the very large tumor is there. So my goal is to do preoperative radiotherapy. So the major problem of preoperative radiotherapy, this is a standard of rectal cancer patients, locally advanced rectal cancer patients. But the problem is near the sigmoid area, daily anatomy is changing too much. And day by day seeing is very important. Would you please start the video? So this is the red one is the day one. Please look at the red one. Can you start the video? So this is the day one. Please look at the red one. And the days are going. So this is 10 days. This is 15 days. This is 20. And this is 25. What is happening? Tumor is just regressing. And the anatomy is wholly changing. If you don't change your daily position of the patient, we unnecessarily irradiate patient uterus because the tumor is smaller and our target is changing. This is why the dynamic looking at inside is very important for our patient. So this is how it looks like 1 month after radiotherapy. The patient is perfectly, can go to the toilet very well, and we start to continue chemotherapy because, you know, we will do a surgery, of course, but we can give all chemotherapy before that surgery. This is a better way to do managing rectal cancer, and for this case, MR-Linac is helped too much because if we use the another technologies, we unnecessarily irradiate very bigger field because of the tumor shrinkage during radiotherapy will change our radiotherapy fields. So again, diffusion changing, so this is one of the case. You know, diffusion, you know, water is going to tumor not goodly because of the solidity of the tumor. Some tumors stop and, you know, fighting with water. And, you know, diffusion-weighted images is changing during radiotherapy. And seeing these kind of images also are also good because this is for prostate cancer relapse case in the prostatic bed area. It is good to see during radiotherapy because, you know, we know that prostate cancer patients regressing not very speedy way because they are mostly slow-growing tumors, and seeing the diffusion changes inside, so these are ADC mapping happening, changing these numbers, saying that yes, you are answering the radiotherapy is very goodly. So you may remember this case from yesterday. So this is also a very good patient to treat with MR-Linac. Why this patient is very important? Because this has an endometrial cancer patient, and there is a tumor near the colon area. So the problem is patients don't want to go to another surgery because previous surgery, patient has some bad experience. And also this is an endometrial cancer, can answer the radiotherapy also very goodly. But the problem is intestines are moving each day. So it is not easy to some conventional radiotherapy systems. You couldn't follow the intestines. But this patient, again, we did everyday MR images. So this is only 3 times of radiotherapy. Every day we see a position of the tumor each day, and we give every day different dose. This is total dose what we give, and you will see the response. So this is, can you start the video? This is how it looks like during radiotherapy. As you see, whole intestinal bag is moving slowly, but colon is not moving too much. The tumor is just touching the colon, and seeing this picture during radiotherapy is again the future because previously we don't see these kind of images during radiotherapy. And again, you will see the PET responses here, and this is perfectly response. This case has also lung metastasis as there. We treat lung metastasis also with lung radiosurgery. Okay, so this is another important example of how we can use MR-Linac. The main problem of, you know, the treating the pancreatic cancer, the changes of duodenum, the daily patient position changes, it is not easy to give higher doses with conventional system. So, and also we know that from very well some studies showing that if you give good enough dose, high dose to the pancreatic area, it can control the diseases. You know that the pancreatic cancer always has not good prognosis, and sometimes always we try to do surgeries working with surgeons very well, but you know that it is not easy to always remove the pancreatic cancer. So this is the pancreatic cancer patients treated with 40 grain 5 fraction MR-Linac radiotherapy and tolerated extremely well. And now this is 3 months already passed and the disease is stable. Can you start the videos, please? And this is how it looks like in the treatment machine, right side and the left side. Also, there is a left side video also. Can you also start that one? So this is how the dose distribution inside of the patient. So another important feature of MR-Linac is very good soft tissue resolution. So this case has only 2 metastatic focus inside of the muscle. So, and then this one, the left one, previously is already irradiated but not answered goodly. And ray radiation is also possible if you see this, if you see the sciatic nerves goodly during MRI. So I think it's very important again to see, because if you do this one as a CT-based Linux, you don't see anything goodly. You know, in CT, you know, it is hard to see how the muscle structures looks like, but inside of the muscle, very small targets can easily be found with this technology, and it also helps us to just spare the organs. Previously, radiation was done. As you see, sciatic nerve is only give no important dose. So also, I will also mention later, but one of the most important part of usage MR-Linac is always prostate cancer. Because, you know, in prostate cancer patient, we have plenty of treatments, and we have sometimes small times of radiation possible. We call it hypofractionated. We sometimes do stereotactic radiotherapy. This is 5 times radiation. And also sometimes we need pelvic radiation. You know, pelvic lymph nodes also should be included for some of our cases. So this case is both pelvis, tumor bed, and also macroscopic tumor is treated at the same time. You can see the bigger dose is red here, and we did the radiotherapy, and you can see the after radiation, how it looks like. And another important patient characteristic of, you know, prostate cancer, sometimes they change their both femoral heads with some prostheses because of some accidents or because of, you know, osteoarthritis or something. And this is another problem of our radiotherapies, mostly in the world, you know, is CT-based. And when you did a CT, this is what you see, or what you couldn't see, because you couldn't see in prostate with tomography, because bilateral hypothesis can cause some artifacts, and those artifacts you don't see inside anatomy. So again, you will need MRI. So it is another important information, because, you know, some people believe that if there is a titanium inside, radiotherapy is not possible, but this is not true. We can do titanium patient with some femoral heads is titanium, but you can do radiotherapy very effectively. And seeing, you know, seeing is not possible with another technology. So this is the only way of seeing MRI. So also, this case is stage 4 prostate cancer come to us for stereotactic radiotherapy, because extremely good response to systemic treatments. These cases also, numbers are increasing. Very good systemic treatments cause very good response in the whole body, and then you have to do some local treatment to the prostate. We know that sometimes surgery is also a possibility for good response cases, but, you know, many patients with metastatic prostate cancer may not want to go to surgery, because it's anyway, this is a stage 4 tumor, then surgery may be too much. But we can do very effective local radiation, and this is a 5 days of radiation. We are using this one 2 times per week in order to just take care on the rectal area. But this is of course, we are decreasing the total treatment time, but we have to increase the daily doses. So this is again why the daily position of the patient very important, because if rectum a little bit change happen, and then you unnecessarily irradiate the rectum, this is again why we have to see inside of the patient. So this is another good thing is we have also Wayne sequences. So this is a new MRI sequence. We can see sometimes lymph nodes betterly with this sequence of radiotherapy. So this is the very important picture of whole my career. If you start with upper left, so this is a full dose of liver 3 metastases we are treating together. Can you start the videos, please? Thank you. So this is the full dose of 3 different targets together. So it is good to see whole targets is treated in one time. And this picture is very good of mine in whole my career. Can you ever seen ever 7 millimeter metastasis during radiotherapy? So it is impossible with another technologies because this is just 7 millimeter targets moving under the respiration, and we are seeing it. And during radiotherapy, it is again very excited times for us to see this kind of images. So if you look at what kind of patient we are treated, so the 1/3 of our patients are prostate and bladder tumors. Another patients are, next patients are soft tissue targets, and then rectum cancer, and then pancreatic and adrenal tumors, and then liver, lymph nodes, and brain. And we, I think one month ago, we start also accepting head and neck cancer patients because we will need, specific some kind of thermoplastic mask. We also start head and neck patients. So this is our whole system capabilities as a little bit. Can we go later? Yes, so this is my resume. So I happy to work with also Liv Hospital, Georgia, Tbilisi. Once a week I was going there. This is before pandemic. We are going also, we have a Turkish team there. We work together with them. So this is also very good for us because working with another center and working, try to get some good results with another center. It is also good experience for us. So also, I like this code too much. So this is not the beam. This is the team issue. This is my team working on this project, and I should say that using MR-Linac is very effective way of treating patients, and I will be very happy if you may have any question to me. Thank you. Any question from audience? I think. And then, thank you.